Okay, we'll get started. It's 1:01 now. So again, welcome everyone to this July CPD session. For those of you who are new to our CPD program, welcome. So I'm Dr. Joyce Ramos, and I'm the facilitator for all the CPD sessions across the year for the CHAP project. So just a bit about myself. I'm an exercise physiologist with passion in exercises medicine for the prevention, treatment, and management of different chronic conditions. So for any exercise-related questions, please feel free to contact me via our CHAP email. So today's session is focused on our fifth module of the cardiac rehabilitation guideline, which is on tobacco cessation and alcohol reduction. And today we have Professor Jacqueline Bowden as our guest speaker, followed by our service of the month from the Limestone Coast Local Health Network to be presented by Frank Circelli. So firstly, we have Jacqueline Bowden. So Jacqueline is the director of the National Center for Education and Training on Addiction at Flinders University. She is a behavioral scientist who has worked at the interface of research and public health policy for more than 20 years, particularly in tobacco and alcohol control, and more recently, other drugs. And lastly, Jacqueline has a background in both psychology and public health. So we invited Professor Jacqueline Bowden here today to help us focus our advice on how to better encourage our patients to cease tobacco use and to reduce their alcohol intake to improve their overall cardiovascular health. Her talk today is titled Smoking, Alcohol, and Other Drug Use in Rural Australia and Their Implications for Cardiac Rehabilitation. So now over to you, Jacqueline.
Thank you very much. So let me know if there's any issues with my slide sharing, but I think it's all there. So first off, I want to acknowledge that I'm on Kaurna land, and I believe most of you might also be as well, and would like to pay my respects to elders past, present, and emerging. And thank you very much for having me to talk about this topic today. It's a really important one. So I'll just give you a bit of background about NCETA. So at Flinders University, we have the National Centre for Education and Training on Addiction, and we're a key national research centre focusing on alcohol and other drugs. And we work as a catalyst for change in the alcohol and other drug field, or what we know as AOD field. So if I refer to it as AOD, you know what I'm talking about. And so our job is to enhance the capacity of workers and organisations to reduce AOD-related harm. And we're funded by the Commonwealth Department of Health. So today I'll give you a big picture. I want to give you kind of a whirlwind tour of alcohol and other drugs and their harms in Australia and obviously in rural and remote settings as well. And talk about it in a cardiac rehabilitation context and assessment and management, and then we can have questions at the end. So on to the big picture. So this is from our National Drug Strategy Household Survey data. So this is the best data that we have in Australia, and it's the most up to date. And it tells you that alcohol is our most commonly used drug in Australia. And that probably isn't a surprise to most of you because many people tend to drink. So this data here shows that 32% actually of people are drinking in excess, though, of our current guidelines. So that's where we become quite concerned. So alcohol causes around 6,000 deaths in Australia each year. And the reason why it does is because ethanol is a central nervous system. It's a central nervous system depressant. It slows down parts of the brain and results in impaired cognitive function. But what it also does is very much linked to many cancers, high blood pressure, heart disease, stroke, liver disease, digestive problems, and around 1 in 10 Australians will become dependent. So there's a dose-response relationship as well, and the evidence of the protective effects is no longer credible. So some of you might have heard, and the community often hear and love to to sprout it back at us, because it was good news at the time that, you know, maybe 1 or 2 glasses of red wine a day have cardiac benefits. But the reality is that has now been debunked. There were some issues with that data. And unfortunately, the risks just far outweigh any potential minor benefits that there might be. Alcohol is, in terms of our drugs, one of the biggest drugs of concern, not because just of the harms to the individual, but also to harms around the individual as well. So physical harms, domestic violence, sexual assaults, that's why it's a big drug of concern in Australia. Cannabis is our other most prevalent drug, and around 11.6% have used it in the past year. Why do we care about cannabis? Well, it contributes around 10% to the total burden due to illicit drugs, causes a broad range of long-term effects, including upper respiratory tract cancers, cardiovascular system damage. There's some more recent evidence around psychosis, particularly for, you know, some long-term and heavy use. Also concern about impact on adolescent development, so motivation. But in the broader scheme of things, cannabis is, you know, not a huge drug of concern, mainly because you can't tend to overdose on cannabis. A lot of the harms actually around cannabis are because it's, you know, it's considered as an illicit drug in many states. And so people then end up in the criminal justice system, which causes harms in and of itself. Tobacco is a big concern still. So we've still got, and it doesn't look like much, but 11% of the population smoking on a daily basis adds up to a big burden of disease. Electronic cigarettes is something that we're watching as well. So around 2.5% of the population are currently using electronic cigarettes. And I'll talk about that a little bit in a minute. But tobacco is the leading preventable cause of morbidity and mortality in Australia. There is just no doubt about it. It causes 21,000 deaths per annum. We're not, you know, we talk about it as a public health success story because we've been able to bring smoking rates down, but it is still killing far too many people. It causes cancer, heart disease, stroke, lung diseases, you name it. There's priority groups, particularly Aboriginal and Torres Strait Islander people, those living in disadvantaged areas, those with a mental illness, people living in regional and remote areas in particular have higher smoking rates as well. So we're definitely not done, and we need to be doing a lot more. So we'll talk about that a little bit later. E-cigarettes is dividing the tobacco control community at the moment. So I'm sure you've probably been asked by clients, you know, what do we do around e-cigarettes? Or, you know, can I try e-cigarettes as a method to quit smoking? The reality is we don't actually, it's too early to tell what the long-term harms are of e-cigarettes. It is very likely, though, that they are much less harmful than manufactured cigarettes, but they're not harmless. They include many chemicals, so 243 chemicals, including 38 poisons like formaldehyde. And the different flavourings have different chemical profiles, and some are very unsafe. So our position around e-cigarettes is that they may be a cessation aid in some groups, but NRT absolutely is much more likely to be safer. And it also is, there's concern around e-cigarettes because they are actually becoming a bit of a gateway to manufactured cigarette smoking among adolescents. So we are watching it closely. Pharmaceutical misuse is another one we're watching quite closely. We're seeing increases in this at the population level. So the most common prescription drugs misused are opioids and benzos. It's become a serious problem in the US and Canada, and we've got evidence of similar problem happening here in Australia as well. It's hard to determine the number of deaths, but they usually are unintentional and involve a mix of pharmaceuticals. So people accidentally taking, a few too many different pharmaceuticals and then overdosing. So we'll talk about how to deal with that a little bit later as well. So the weekend drugs, just for your background, cocaine and ecstasy, around 4.2% of the population use cocaine and around 3% use ecstasy. Cocaine's a stimulant, so it speeds up the messages between the brain and the body. It's associated with cardiovascular conditions, a higher risk of stroke. Prevalence of cocaine use has doubled since 2013, so we are watching that too. What we have seen is an increase in the eastern states, and what we tend to see is South Australia follows suit in time with the eastern states. The thing with cocaine, though, is that it is quite expensive, so it's much less likely to be used, and when it is used, it's more likely to be used on the weekend. Ecstasy and MDMA, we haven't seen too much change over time with that. The issue we have with that is it's mainly around poisoning, mainly around overheating, heart attack, and that's why you might hear a bit of a talk about pill testing to make sure people understand what's in their pills before they take them. And that's a harm reduction approach, assuming that, there are segments of the population that will always want to have some form of a drug, and it's better to make sure that if they are using a drug, that they're using a less harmful one. So methamphetamine, you've probably heard this in the news headlines a lot. It's really only used by around 1.4% of the population, but its use is higher in regional and remote areas. You'll hear particularly some towns and cities have higher meth use rates, and that's often because of supply. So it's very strongly linked with supply, and a lot of talk about it being available more on the kind of towns that are on the trucking routes and things like that. So you'll see headlines like this, which makes you think that meth use is much higher. There's a lot of media hype around it, but it is, only a small proportion of the population that use methamphetamine and use it regularly. But it is a highly addictive synthetic stimulant. It's usually smoked, sometimes injected. It causes, though, huge harms to the individual, a big downhill spiral very quickly. And so issues with families as well, health and social problems, violence. It's recently been linked to Parkinson's. When we talk to experts, they tell us that you can see a big breakdown of family and community. So it affects everyone around that individual if someone is using methamphetamine. GHB and heroin, they are much less likely to be used. We did a study on harms of drugs in South Australia recently, and we didn't even have fantasy on our list, but the police made sure it was now included on our list because it's being, we've had some overdoses recently. So it's a colourless, odourless, bitter or salty liquid, and it's a nervous system depressant. So the overdose risk is very high and it causes respiratory collapse. So we have had a number of overdoses with fantasy. It tends to be used by specific subgroups of the population at the moment. It's not widespread use, but something to be aware of. Heroin, we don't tend to see as much of in South Australia. It tends to be more prominent in the eastern states, but it interacts with opioid receptors in the brain. It's commonly injected. It's a nervous system depressant and highly related to dependence and overdose. So how do, our main drugs? So I've talked about alcohol being our, primary drug of concern because of harms to the person and to the individual around them. And tobacco causes the highest burden of disease overall. So those are our two major drugs that we need to be aware of. And those two drugs are being used more commonly in country areas in South Australia and across the country. E-cigarettes as well are being used more in regional and remote areas too. So what we tend to see is that basically tobacco, alcohol, and other drug use is higher in regional and remote areas. There's a lot of theories around why that might be. Some of it's linked to socioeconomic status, some of it's linked to being isolated, some of it's linked to boredom, some of it, the pharmaceuticals, misuse of pharmaceuticals can be linked to not having enough access to services like physiotherapists and a whole range of other services that we might have in metropolitan areas. So there's a whole range of theories and reasons for it that compound. We've done some analysis recently, just really for this presentation to give you a sense of heart disease and recent use of selected drugs. And you can see that we actually have fewer people with heart disease that are using alcohol or tobacco, cannabis, methamphetamine, but a higher proportion using painkillers. And the same for hypertension, not as prominent use of painkillers there. Similar rates of alcohol consumption in excess of the guidelines. So now moving on to the next topic. In terms of psychosocial aspects in cardiac rehabilitation, there are a broad range of psychosocial risk factors that are implicated in alcohol, tobacco, and other drug use, as well as CHD. And they are, and you would know these, lower socioeconomic status, social isolation, stress, anxiety, and depression as well. So I guess it's important to be aware of all these things when talking to individuals, that it's not just about the fact that they have substance use issues, that they have a whole range of other things that are happening around them as well, that absolutely, and sometimes we find if they're addressed, can help set a better platform for people to be able to, say, quit smoking or reduce their alcohol use, things like that. So managing some of these other issues around stress might be a better way to tackle some of these topics before even tackling some of the substance use issues. So this is a study from America, and it shows the risk of 30-day readmissions in heart failure patients with and without substance use disorder. And you can see here that it's literally just a higher risk of readmission by any of the substances used here. So clearly some things to be mindful of here. And the independent predictors of it were lower household income, leaving hospital against medical advice, other comorbidities, anemia and anxiety disorder, and opioid use as well. So in terms of assessment and management with alcohol, as I mentioned, the evidence of the protective effects of alcohol being, the evidence around the protective effects of alcohol is just no longer credible. So basically those studies have been debunked a little bit because of those that weren't using alcohol anymore tended to have higher had other issues. And so they've been discredited. So neither the Heart Foundation of Australia nor the WHO recommends consuming alcohol, including red wine, to prevent cardiovascular disease anymore. You might all know, but just a reminder that the Australian alcohol guidelines have recently been updated. So they used to say no more than 2 standard drinks a day, and now they say no more than 10 standard drinks a week, and no more than 4 in any one day. And the reason why these guidelines were updated was primarily because of the more recent evidence emerging around cardiovascular disease, cancer, and also young people as well, adolescents, and the link between alcohol use and affecting brain development. So they definitely needed to be revised. This is really based on a dose. This is really sort of based on minimizing harms. But if you were to, if someone were to say, how would I reduce my risk of cancer? Unfortunately, we would have to say any amount of alcohol is linked with cancer. Even at low levels, there is a link with breast cancer. So that's not good news for people to hear, but it is important for people to, I guess, know and make informed decisions. And that's what we really think is important, is for people to be making informed decisions. So in terms of practice statements, that the old practice statement says 2 standard drinks a day, but it really is now less than 10 standard drinks per week. We recommend offering brief advice and counselling to encourage reduction of alcohol intake. If you find that someone is admitting, and we'll talk about the audit tool in a minute, but if they are showing dependence, then we recommend that you contact the alcohol, get them to contact the Alcohol and Drug Information Service, or for you as well, Drug and Alcohol Clinical Advisory Service is available as well, and I'll show you that in a minute. So the audit tool, and the link there that I've got up there, auditscreen.org, check your drinking. If you don't have access to that yourselves, you can just go onto that and fill it out on behalf of someone when they're in front of you, and it will literally give you a score, like a score and a little bit of a brief intervention option straight away. So ideally, we want to be supporting maintenance if they've stopped drinking. Provide advice that's simple and focused on reducing hazardous drinking, brief counselling and continued monitoring, and then continuing to monitor them if they're showing alcohol dependence signs. So Drug and Alcohol Services SA have a huge list of areas that you can go to and information that you can read about around how to manage things like alcohol withdrawal using the audit tool. It's important to be mindful that if someone is showing measures of dependence, that it is always good to get advice, because alcohol is actually one of the worst drugs to detox from and can cause some big issues if done very quickly. So always best to seek advice around that too. And as I mentioned, I'll just go back a couple, that Drug and Alcohol Clinical Advisory Service down the bottom, that number there is a good one to contact, and they're available between 8:30 and 10 p.m. every day. So now on to tobacco. As I said, it's the leading preventable cause of morbidity and mortality in Australia. It's really important to know that 68% of smokers want to quit. And that's something to always be mindful of when, if you're sitting there concerned that, having this conversation might be a difficult one, that actually most people do want to quit, and they're not going to be, shocked by you suggesting that it's something that they should consider. It is a really important window of opportunity. Health professional intervention work. So about 10 years ago, in my role as evaluation officer for QUIT, we looked at health professional referrals compared to your average person contacting the QUIT line, and we found that those that were referred by a health professional were much less likely to quit smoking and retain and maintain being quit. They just saw it as credible advice from a health professional, and it motivated them to actually try to quit and maintain their quit status. So you are in a powerful position and a very motivating position, and it's an important window of opportunity. There is data that shows, unfortunately, 6 months post ACS, only 1 in 3 smokers had quit. So it's just not being used enough, and is, as I mentioned, a really good opportunity for intervention. So what we suggest is the Ask, Advise and Help model is the evidence-based model. We encourage those who continue to smoke to really cut back, but ultimately what we're looking for is cessation. The reality is that every cigarette does do you damage. You probably heard that campaign before, and it is true. It's unfortunately the truth. Some people do find it helpful to cut back though before they completely quit. And we are seeing people sort of saying to us these days, I want to quit my own way. And so important to be able to kind of give them some options. But number one, we recommend ask all patients about their smoking status and document this. Advise in a clear but non-confrontational and personalised way about the benefits of quitting. So there's very immediate benefits of quitting. When we sort of looked at modelling of cessation, one of the first the best return on investment is getting smokers to quit smoking, and we see benefits straight away through cardiovascular benefits and less likely to end up in hospital. And then help. So the best evidence tells us a combination of counselling, and an option is the quit line. We know you're very time poor, and so the quit line could be a good option, but also nicotine replacement therapy as well. Quit Victoria have online training, and it's free to Victorian, SA and WA learners, and it's $20 for others. They've got a huge amount of resources online for health professionals working in different settings. So I'd recommend you go on there. They've got videos on how to refer patients to Quitline. They've got the referral form, things like that. So huge amounts of information there. In terms of NRT and safety, it's safe to use in patients with stable cardiovascular disease. So this is the RACGP supporting smoking cessation document, a guide for health professionals. But it's to be used with a bit of caution in patients who've had a recent myocardial infarction or unstable angina, or have had severe arrhythmias. So that one's a bit, to use with caution. E-cigarettes, there's now an NHMRC position statement on them. They're not proven safe and effective for smoking cessation aids particularly. But, some smokers will try everything and then they'll tell us that the only thing that helped them to quit was an e-cigarette. So I guess it's just one of those things that to have up the back of your sleeve if needed, but be really pushing the NRT as the first option. The reality need to do more research to confirm the harms and benefits from e-cigarettes. So cannabis. There's several published case series and reports that have demonstrated an association between cannabis use and acute coronary syndrome. There's no specific statements for cannabis, only that any illicit drug use should be recorded, so make sure you're recording that. But cannabis use is associated with increased risk of arrhythmia, which is rare, but it's really important to inquire about it, I think. We're starting to see more and more people being prescribed cannabis for medicinal purposes. So that's something to be aware of. So there is some TGA guidance on medicinal use of cannabis, and it provides background for health professionals and patients about medicinal cannabis. basically the guidelines say there's limited data to support the use of medicinal cannabis in many circumstances, but it is being used and being prescribed. But you should just know that cannabis products containing THC are generally not appropriate for patients who have unstable cardiovascular disease. So it is something that is worth asking people about and being aware of. Pharmaceutical misuse is, I guess, an issue that we're grappling with in Australia now, and there is now a product called Naloxone. There's an ethical and clinical argument for Naloxone to be provided when a patient has been prescribed opioids, particularly in regional and remote areas. What it does is it temporarily reverses the effects of an opioid overdose, and it's administered usually through a nasal spray. It can be an injection, but mainly a nasal spray, so it can be given to people to take home, and it blocks the opioid drugs, but it's still important to call an ambulance because it only lasts about 30 to 90 minutes after someone has overdosed. So it's important to call an ambulance. So there's now a national take-home naloxone program available in some states. It's a bit of a trial, and people who are at risk of an opioid overdose or adverse reaction can make use of that. In terms of other background information that you might want to look at, we've got a report through NCETA on pharmaceutical misuse, and it talks about a whole range of other things, including effective management, opioid tolerance, preparing medical practices for patients with opioid problems. So you might want to follow that and look up our website. But just to summarize kind of what I've gone through today, the primary drugs of concern in Australia are tobacco and alcohol. There's no doubt about it. The prevalence of alcohol and other drug use is higher in regional and remote areas. Be wary of cannabis for medicinal purposes for the issues that I've outlined, and be wary of e-cigarettes as well because of the fact that, from a public health perspective, they may help one or two individuals, but on balance, the evidence is still pointing to the fact that NRT is a better, safer option. And stick with evidence-based approaches, including places like the Quit line and NRT, the approaches outlined by Drug and Alcohol Services SA, and naloxone is an important one for opioid misuse and overdose. So now I'll hand over to questions, and there's my contact details. You're welcome to contact us anytime if you've got further questions. We've got all sorts of training modules on our NCETA website for you to use at your perusal, and but yeah, welcome your thoughts on anything else that you think you might need going forward as well, and we can look at working up those things too.
Fantastic presentation, Jackie. Thank you so much. That was so informative.
Thank you.
I'm definitely skipping the pub at least for this week. All right. So we'll leave the questions until the end, but before we move on to the service of the month, are there any burning questions now for Jackie? At least one or two. All right. Nothing so far, but we'll leave it at that for now, Jackie, while they formulate their questions.
Sure.
So for the next part, we have the service of the month. Oh, sorry.
Sorry, we're trying to get a question through.
Oh, fantastic. Thank you, Robin. All right.
Jackie, I just want to say that was amazing. So thank you so much. And I think that we really appreciate that you're here today under the circumstances. So thank you for being so professional.
Sorry, Robin. It's just a bit echoey. Jackie, were you able to hear that question?
I don't know whether I could. Sorry.
Okay, so
that's better.
One strategy that I heard about just recently is taking someone from AA on the cardiac ward round, and as the doctors and registrars and nurses go around, that they might make an assessment and introduce the AA person to, and then they come back and follow up for a chat. So I quite remember a number of people could have used, their services and helped you. Are there other strategies like that that are at that immediate acute phase where we can intervene and come to the bedside or implement strategies in cardiac rehab?
I'd probably have to take that question on notice, actually.
Right.
I see we've got Jeroen Hendricks online who might actually have a really good response to that one. But yeah, I'd have to get back to you on that one.
No problem. There's lots of little strategies out there about this. The other thing was I was going to ask the audience a question, and that was, how many patients are you seeing with drug-related cardiac events, and do you think it's increasing? Just the general open discussion. Tracy, do you want to?
I think it's increasing from what I've seen at the ward level. People coming in post having taken probably methamphetamine normally, cardiac arrhythmias or MRI, things like that.
I know that one of our absolute favourite co-design patients, a consumer who comes and works with us, is a young real estate agent who had a cocaine habit and then had his MI and went to rehab, and now he's got heart failure. So, and he's quite open about it. So obviously he's not doing coke anymore. And I do remember on ward round, this gigantic bikie and young, and the consultant just said, I'm pretty sure your heart attack's related to your coke habit.
Yeah.
And that's the first thing you have to do is stop. And then afterwards I thought, he never told anyone he had a coke habit, but the consultant recognised the sniffle and the black nose and the black teeth and a few other coke signs. And so he said, I took a guess on that. And he was actually bang on. So that was an interesting situation. But people aren't connecting the dots between, and I know with cancer, we've been telling women with breast cancer for more than 20 years that alcohol is a risk issue, and they just, what? Oh, sorry, was that just my phone's ringing? Yeah, that's the response we're getting to the state survey about a year ago, and we said, did you know it's a risk factor? Would you be interested in us referring you to alcohol, services? And they said, oh, no, thanks. It's been a bit tough going through chemo. It's the only thing I can taste at the moment. So,
it is a big area that I think we need a national campaign actually to highlight the link between cancer and alcohol, and we've been pushing for that. But absolutely the link around cocaine and heart attack is a big one, and people aren't aware either about, mixing alcohol and cocaine together. A big risk factor for heart attack.
That consultant who seemed to know a lot about cocaine, he also told me that the best way to get men to give up is to tell them it makes them impotent. Yeah. Did you know that is caused by that? And apparently that's very effective. Yeah.
Jeroen, you've got a question. You're on.
Yes, hi, Jackie. Thanks for a great presentation. Great.
Oh, chipmunks.
Sorry, you're on. Yeah.
What's
happening?
Try again.
What happened?
Now? Can you hear me now?
I can hear you.
Yeah, we can hear you.
Do you have to say something else?
This is quite entertaining, you're on.
Happened, but can you hear me or not?
Not really, no.
Yeah. I'll come back to you then.
It's very cute.
I love it. All right, we'll leave the questions at the end, Euron. Okay, so we'll move on to the service of the month. So this will be presented by Frank Circelli. So Frank has worked in the public health service since 1990. He commenced at FMC, so Flinders Medical Center's graduate program, and worked in coronary care unit, completing his postgraduate coronary care certificate. And here, Frank was introduced to cardiac rehabilitation. And in 1998, Frank returned home to Mount Gambier Health Service, working in the high dependency unit, completing his postgraduate high dependency certificate and advanced life support training. Frank was also the duty coordinator for the hospital. And in 2009, Frank joined the BCIC team full-time as a cardiac rehabilitation nurse consultant. And lastly, in 2009, Dr. Phil formulated the first regional heart failure clinic with Frank and Dr. Christine. So over to you, Frank.
Thank you very much for this opportunity to speak. Mount Gambier, the population base of our region makes up about 3% of South Australian population. We have 7 district councils there, and we make up about 15% of our GDP for the state as well. And mainly it's forestry, agriculture, construction, tourism that make the majority of that particular income for the state. Majority working class in its background. The major risk factors we have down here in relation to cardiovascular risk factors is obesity and physical activity, roughly 50% each of that particular population. Smoking is also an issue, and we're sitting at about 17.8%, which is well above the national average. And I haven't got the statistics on the alcohol, but I would imagine Dan Murphy being one of the biggest turnovers of the state in our region, that it is high as well. Sporting participation has dropped off, unfortunately, in this region, specifically the junior competitions. We have lots of issues now in regards to filling teams in all aspects of sports. And our fast food outlets have also significantly increased as well over the last 4 or 5 years. The picture of the Blue Lake today is looking very blue, but I can promise you it's not very blue today. And it is extremely cold down here at the moment as well. So you're not missing much from that perspective. In 2009, we were very fortunate that we had some very proactive and supporting directors and CEs at that particular time. And they put a proposal in, and they put down a wonderful proposition in regards to a BCIC team. The team is currently made up of 4 RNs, 2 job share the respiratory position, and they are still in place today, many years later. So a very experienced team, a very good team, and the team was also formulated with some allied health built into the budget as well, which gave us some excellent input from their professional lines, and also accountability from a team perspective as well. So it works really well. Referral numbers have been strong and remain strong. Some of those contacts are very brief and once off, but others have been on our books since 2009. So a very diverse group. Our main focus is obviously hospital avoidance, decrease ED presentations, and decreasing occupied bed states. We collect that data, we present that data, and I suppose that's why we're still here in 2022. A big player in all this has been VCC lately in the last period of time. With their support and their intervention, it has really helped. And in 2020, it really helped us in reducing hospital admissions and ED presentations. Just the clinical experience in regards to that team, there's 20 years of cardiology and medical experience, there's 30 years of acute ED experience and 30 years of community nursing experience, which really comes into play when the team has to operate in a multidisciplinary approach and also operate in a backfilling approach as well, supporting each other through those periods of leave and unexpected leave as well as we're in the moment. So when we look at referrals specifically to cardiac rehab, I'm not sure what's going on, but COVID has certainly slowed things down. So pre-COVID, pretty strong numbers there. Not quite sure what's going on lately, but maybe things are changing. But at this stage, the numbers remain strong. Our attendance and breakdown of those attendances are relatively standard, I think. Group attendance is not as high as we would hope, but once they do attend, their completion rate's good, and those that do complete really do show some really good outcomes, both physically and emotionally. We do have some options for individuals that are motivated to stay on. We do have a maintenance class that continues for another 6 weeks. The attendance issues probably have a little bit to do with the inflexibility of the program. It is sort of set fairly concretely, and the COVID concerns as well recently have sort of affected the face-to-face contacts as well. We're still receiving some really good outcomes, positive feedback, and some really good improvements. Our referral base is obviously very dependent on Catch and Flinders Medical Centre, where 95% of the cardiac referrals come from. We do have a small percentage of those chronic ischemic heart disease clients that are re-engaging from a hospital perspective. The GPs also pick up a few of the ones that have sort of got through the cracks, especially from Victoria side of the border. And it's a small community, so people talk. So there's a few self-referrals that come through as well. I thought we'd have time just quickly to talk about one particular component of my role, and having that acute experience really gave me a great platform to take this opportunity. It happened in 2009, and it really showed what can happen when you do have individual champions that work and visit a particular region. It was a structured program. It got up to 140 clients. It worked really well. It was face-to-face bi-monthly clinics, and the VC component on a mobile telehealth unit via TMS worked really, really well. It was a fantastic visual and audio service. With a clinic like this come the heart failure cardiologists, come the networking of the heart failure nurses through Flinders Medical Centre, and come the face-to-face educational centres. We have, medication representatives, Rachel specifically, that comes down and really promotes the heart failure side of things from a medical staff, from students, pharmacists, GPs, and that flows onto the clients in regards to their improved outcomes. The clinic at the moment is in a restructuring process. COVID obviously has affected things. Christine's also moved back to staying in Adelaide now. So we're starting to restructure that around James and working forward to continue that particular service. Cardiac rehab takes about half of the rest of my time. And that basically is a pretty standardized program. The positives or things that may make it a little bit different from other areas is we do have the ongoing maintenance class for another 6 weeks. We do have some home-based community programs. We a couple of years ago, our physiotherapists individualised the program from an exercise perspective, so that really allows that rolling group to work well. We do have an OT that has a real specialty area in scar management. So that really helps for those more sensitive scar issues. I do enjoy taking my ECGs and reading my ECGs. So I still take those on a need basis for a lot of the heart failure and acute cardiac presentations. We do have a cardiac ECG probe as well attached to our iPad that we can take into the clinical setting should we need to. We have a clinical psychologist on and off depending on availability, and we also have a quit smoking counsellor as well that really helps that particular process. Some of the other positives from a cardiac rehab perspective, and this is where the accountability and the budget really help in regards to our allied support. We have fortnightly gatherings and where we discuss specific issues, all positive in relation to improving outcomes. We have smart goal setting, sometimes by myself or the occupational therapist. We have the 6-minute walk test as well. That really highlights some of those improvements. So a really good positive team approach and a really good program with some really good outcomes. COVID. Well, COVID has absolutely smashed things here from a program perspective. I think the only positive was that we were seen, the BCIC team was seen as an essential service through that particular process. We had some wonderful support from CATCH and CHAP as well, people that were very comfortable on this new platform that we had to operate on and very experienced in that. So that was essential and very positive. The one-on-one appointments could continue, obviously under strict guidelines. We had issues there in relation to staffing being comfortable with that, and also clients being comfortable coming in. We do sit inside the hospital premises, so clients found it a little disturbing in those early days, maybe coming to a high-risk area like the hospital. But we continued. When things did stabilise a little bit and we did get groups up and going again, there was a little bit of stopping and starting depending on community numbers. So that really impacted on that continuum of care and changing platforms as well. But as you can see on the slide, we did have some platforms that we used, and we had some very proactive physiotherapists that helped us as well. And we did manage to keep the program alive in one way or another. So going back to improving activity and participation levels, as we discussed at the start of the presentation, Mount Gambier as a community has taken this very seriously and has spent humongous amounts of money in regards to upgrading specific activity guided structures. So one is the railway land, the top left there, which we've turned into a walking area, and there's some commercial businesses now opening up in that area. This time of the year, it is a little bit tough along there, but in the spring and summer months, it's quite pleasant. And those occasional warm evenings as well. The screen at the bottom is a 57.3 million recreation centre that's just about completed, and that will really change the way people can access sports, both indoors, covered, protected from the weather, and participation. So that should really help things, we hope, and we hope that works well. The other positives that came out of COVID were the technology options. And we could see here the group going, the OT that particular day had an unwell child, but she was home, but she's still able to link in and give her presentation. So it went really well and it worked really well. And basically Teams does work really well here. Health Direct, we do have some issues with that in regards to connection, and certainly outside the Mount Gambier region in those more distant satellites regions, we do have some connection issues in regards to technology. Well, that concludes, on data collection, the last thing that's obviously very important to continue this service going, then it's important that we do maintain an effective data collection and analysis. And I know CATCH is really helping us to achieve those goals and maintain the services that we do have here. Thank you.
Thank you so much, Frank. What a very impressive facility and team. And I'm also very impressed with the array of clinical assessments that you have on site. It's fantastic. And the fact that you're individualizing exercise program, of course, according to the needs and goals of your clients. It's absolutely fantastic. Thank you so much for sharing. So on to the next session now, which is the questions and answers. So are there any questions for Frank and Jacqueline before we end the session in 4 minutes? I know Euron, you did have a burning question earlier. Would you like to kick off? Is Euron still there?
Frank, it's Helen here. Joining the two sessions together, drugs, alcohol, what do your patients look like as a regional centre in South Australia? The reason I'm asking is because when I was at Pinaroo show last year, apparently a local Mount Gambier meth dealer went to Melbourne to get her stash and came back and gave everyone in Mount Gambier COVID, so they had to be shut down. This was the gossip at the Pinaroo. And then the Pinaroo show people saying, yeah, Mount Gambier is the meth capital of South Australia. So I'm there, no, really, it's a beautiful town. How can that be true? So give us a little overview of the sorts of clients that are coming through rehab that might dispute that gossip at Pinaroo show.
I think drug and alcohol's an issue in all communities, and ours is no exception. I'm seeing less of it now, to be honest.
Good.
4
or 5 years ago, we'd get the occasional young individual presenting with heart failure because of their lifestyle choices. Yes, there's some tough little areas in this town, but generally it's still a relatively safe town from that perspective. But yeah, I'm not seeing as much at the moment. It's mainly more alcohol-based issues that I'm seeing.
Just on that meth topic, we've put up for an ARC grant, and we're looking at meth use in a number of towns in Australia, and Mount Gambier has been identified as one that we would be probably looking at because it sort of definitely does have a kind of high rates of meth use.
Okay, are there any other questions for our speakers today? Is Euron still there?
Looks like he's left.
Okay, if there aren't any questions for our speakers left, first of all, I would like to thank Frank and Jacqueline again for their time today. And just a reminder for the next session, everyone. So we are focusing on Module 7, which is managing medical risk factors. And we have Associate Professor Margaret Arstall talking to us about Girl Talk, managing CBD in women during pregnancy, menopause, and beyond. Again, thank you, Frank and Jacqueline, for coming in to talk to us about a very important topic. And again, I won't be in the pub this week, Jacqueline. All right. Have a good day, everyone.
Thank you.
Thank you.
Bye.
Bye-bye.